Okay, we're going to talk about ultrasound for DVT, deep vein thrombosis. And I just want to start out with an interesting case I had about a year ago. These two girls who are Avery and Chandler. Basically, what happened was Avery, a 16-year-old female, presented with 3 months of dyspnea and exertion, one episode of near syncope. She was a soccer player, and she almost all but passed out on the soccer field. Now, she has a twin sister named Chandler, who maybe had some symptoms but wasn't really talking about them. But it started with Avery with the near syncope. She went to several emergency departments, and with that 3 month history of dyspnea, she eventually got referred to pediatric pulmonologists, two separate pediatric pulmonologists. And people did workups like chest x-ray and labs, and she wasn't anemic, and her lungs looked all right on a chest x-ray, and that's pretty much, and an EKG, and the EKGs all came back pretty normal, and that's pretty much where the workups were stopping. This was, now it was our turn to take a crack at it in the UCI ER, and what we did was we went in there and we took a look at her IVC. I just wanted to see how flattened out her IVC was in the setting of syncope. I thought, well, maybe she's just really dehydrated. And as I'm talking to her and her family, I'm getting a longer history. It started to come out more that she's had this sort of recurrent dyspnea with this long workup. And this is her IVC here in this longitudinal view. I'm not sure if you can see this, but this is a large structure that's sitting in her IVC. And that's the long axis. Over here on the short axis, we see the aorta. We see the IVC next to it, her contracted gallbladder. You can see it's up here. It's got nothing to do with the case. It's just kind of cool looking. Look at that contracted gallbladder. Love those things, like little baby gallbladders. But anyways, back to the IVC. This is her IVC here. It's got this structure in it. It's like, what's going on with this IVC? What? I wasn't sure what it was. I thought at first maybe she had a tumor in her left kidney that had made its way through that left renal vein and up into her IVC. But that wasn't the case, actually. When I started to look around more, I found that actually she had clot. This was all clot here sitting in her IVC, and it extended down her body a little bit as well. And so you can see this filling defect here, So this whole time she was having respiratory distress from DVT and pulmonary embolisms, and throughout her venous system, she had this huge clot burden. And her only risk factor was that she recently started taking birth control pills. Now, that does, the birth control pills definitely is one of the things that can be a procoagulant. And then when her sister came in, her sister had the exact same symptoms that she sort of talk about once her sister was found to have these DVTs, and I diagnosed her sister also with the same exact problem, same exact clot in the same locations. So she ended up getting put on anticoagulants and did very well, actually. And that's why they wanted to take a picture, because it was kind of a happenstance diagnosis. And I think that's one of the cool things about ultrasound. It lowers your threshold to search for life-threatening conditions. Very easy to do. Just plop the probe on, and you'd be amazed at the things you stumble across when sometimes you're looking for something and you find something else you weren't even expecting. And there could be a journal called the Journal of Unexpected Ultrasound Findings, and I bet we could publish in it every month. So let's talk now more about how to do, this is going to be a very practical talk about how to do a DVT study. You basically take a linear or a curvilinear probe, depending on how big the patient is. On smaller, thinner patients, definitely want to start with this linear probe. It's designed for the vessels. Sometimes people call it the vascular probe. Or in larger patients, you could use a curvilinear, quote-unquote, abdominal probe as well. You're not going to want to use your low-frequency, phased array transducers here. And you're going to start up in that inguinal area. This is the inguinal ligament, sometimes called Poupart's ligament, and this is how proximal you want to start. I like to say, if it's not getting awkward between you and the patient, you're not doing this right. You're not superior enough where you start the study. So you can see here the vein is here, the artery is here, the nerve is here, but you're looking specifically at this vein. And the superficial and deep femoral veins, you'll see them branch off pretty quickly as you start to march down the leg, and you'll see this deep femoral vein. It branches off and it goes right up down next to the bone. And so you want to look for that as well. You want to follow this, the common femoral vein as well as this deep femoral vein as far as you can down the leg. It's going to branch off down here as well. And you'll see this common femoral vein go all the way through what used to be called the superficial femoral canal or adductor canal. It's a difficult area to insunnate this femoral vein in, but you can get it if you give it a little patience, and then eventually you'll be down here in the popliteal vein. And what you want to do is you want to compress. So you can see here, this is very proximal. It's where the common femoral vein is still just all by itself without any branches off of it. But you can see the superficial and deep femoral arteries have already sort of bifurcated. And the vein is the more medial structure. Venous rhymes with penis right here, so that's how I know venous penis, that's the more medial structure. Or you could say venous vagina if you'd like. The indicators to the patient's right, medial, lateral. So this must be the left leg. The other way you look down and see your hand on the left leg, you confirm you've definitely got your orientation correct. This is the area that you're going to insunnate all the way down the leg and then into the popliteal fossa. This being the adductor canal, the superficial femoral canal, very difficult area. I say relatively difficult area to insunnate, but you can do it. And then the popliteal area is very easy. You get behind that knee and you compress the knee, and the popliteal vein is seen more superficially and the popliteal artery is deeper. So you could say the vein comes to the top in the pop, and you're going to take one hand, put it on the knee, and then the other hand on the probe, and you're going to push your hands together, and you'll see the bifurcation or sometimes the trifurcation there in the popliteal fossa. So once again, this would be a still image protocol to rule out DVT in the common femoral area. Here's your saphenous vein, your common femoral vein, and your common femoral artery. So venous rhymes with penis, so this must be the right leg, as long as your indicator is to the patient's right. And with compression, the only thing open is the artery, the common femoral artery. So everything got compressed here, meaning there's no clot when these walls coapt. Coaptation is the term we use for these venous walls to come together. And with the video protocol, you can see it here, superficial and deep femoral arteries. Here's that common femoral vein nicely compressing, and this must be the right leg. Enough pressure when the veins collapse. You're probably putting too much pressure if you start to see the arteries collapse. And when those veins don't collapse, here is the superficial and deep femoral arteries, common femoral vein. Saphenous was up there a second ago. Saphenous is over here. You see that it is not collapsing, therefore there must be some structure in there, aka a clot in the common femoral vein. We see it here as well. Now we're in the popliteal vein. The vein comes to the top in the popliteal artery, popliteal vein. Nice coaptation there of that vein in the popliteal. We could probably decrease our depth a little bit. This is pretty deep for any linear probe to go, almost 6 centimeters there. If you decrease this depth in a linear probe, this is going to widen out on you. You're going to get a lot more information on the screen. Here we are now in that popliteal fossa. Unfortunately for this patient, there is a clot here. Here's the artery, here's the vein, and as we compress, that vein stays open. So this is what it looks like when you've got a clot in the popliteal vein, failure to wink back. Compression is performed at the level of the inguinal ligament down to the bifurcation of the popliteal vein. You're going to get through all this area as best you can, this being the trickier area, but take a little time and get through as much of it as you can. It is a little bit more challenging to get through this region here, but you get through it and then you're in the popliteal fossa. So this was an interesting study looking at the 2-point compression ultrasound, because the way we used to do it until this, frankly, the study came out last year, was we used to look in the common femoral vein and we used to look in the popliteal vein, and we kind of ignored the deep femoral vein and the femoral vein, this superficial area right here that I'm telling you about. And so we did this 2-point compression here and then down here, and then the problem is if you look at this study, even though it was retrospective, and these were all scans that were done in radiology, these point of care doctors were saying, hey, what are we going to miss? What are we missing here? Well, they looked at a whole bunch of patients, and the 362 DVTs that were found in these 2,400 patients that were scanned, actually 6.3% of them were found in this area between these two compression sites. So that's why I'm saying it's important to keep an eye on these veins as well as you're coming down the leg, because you wouldn't want to miss up to 6% of clots isolated to this area that were not found in the fem or the pop, if you believe the study. So it's just something to keep in mind if you really think your patient's got a DVT. get into this deep femoral vein and get down through this femoral vein. This was another study looking at some mistakes that residents had made in Vegas doing ultrasounds, and they basically, this was a better design study. It was prospective, and after some brief training, the residents did 2-point compression ultrasounds, and then they all went on to get a radiology full-on leg ultrasound as the gold standard. And the residents didn't do very well. And when you go back and you look at the problems here, you'll see that 4 clots were isolated on the radiology studies into that superficial femoral vein, that adductor canal area. So that's how you can miss that. And also pay close attention in the popliteal vein. They had some problems back there as well. I mean, this sensitivity is not all accounted for this. A lot of it had to come from the poor job they're doing in the pop as well. So just make sure you're getting good visualization here. Now, a lot of people ask me about Doppler, and Doppler is super fun to geek out on and play with, and I totally agree. It's awesome. But turns out that if you look at all the literature here, it's really the compression alone and not the color Doppler. So this is how you do it, though. So this is how it's called augmentation. So like you put the probe up here in the femoral region, and if you squeeze the calf and you see good flow up here when you're squeezing the calf down here, backflow up the vein here, you assume that there is patency between these two areas. And that's the idea. And if you don't, if sometimes you'll see a filling defect, that's what this looks like here. This is the common femoral vein with a filling defect seen here with augmentation using power flow Doppler. But this doesn't really work. There's all kinds of reasons why it doesn't, I won't go into, but don't rely on this. You can kind of mess around with it, but it's not something to be relied upon to rule in or out a DVT. There's also issues with spontaneity. You should just spontaneously see blood flowing without having to squeeze the calf. And as the patient breathes in and out, you should see increases and decreases in Doppler signals, but also it's more of a subtler, more of an advanced technique to suggest there may be a clot further upstream, like in the iliacs. You know, for our purposes here, I just, the main thing for me is getting all the way down through that superficial femoral canal. But you could see here, what do you guys think about this? So what leg is this? So if this is the femoral artery and this is the femoral vein down here, we see non-compressibility in this femoral vein on this patient's left leg, right? Because the vein here is more medial than the artery, and this must be the right, patient's right, so this is the left leg here. Good. All right. Now you would think that when you would see clot inside the vein, they go, oh, there's clot there, therefore there must be, I see something there, therefore it must be clot. Well, sometimes slow-flowing blood can look like clot even though it's not. So, and there's a variable process there of the thrombolytic process going on. So, you know, sometimes there's visibility of the clot, sometimes there isn't. Slow-flowing blood can definitely look like a clot. So just be careful with clot echogenicity. I would not rely upon that one way or the other. It's the compressibility, not the echogenicity, that is or is not the DVT. I don't know if you can see here. So when I first looked at this, I thought, oh man, there's something in here. Look at this. What is this stuff in here? You can see it over here as well. This must be a clot. Wait a minute, no, it's easily compressible. You could see it both in the longitudinal plane and in the short axis. Same patient. We're just demonstrating how slow-flowing blood can sometimes mimic a clot, especially if you using a higher frequency. This is a very high-frequency transducer here, HFL, high-frequency linear transducer. The frequency is really high. You're actually able to make out some of those grayscale reflectors that is just slow-flowing blood. And so on this patient's left leg, I see really good compressibility there, so therefore there's no clot. And if you really kind of tie it all together, you pull a table out of some radiology textbooks, you'll see stuff like this. The primary diagnostic criterion here is actually the non-compressibility, while all these other things here really have to do with the secondary diagnostic criterion, and I really don't rely on these things at all. I'm all about the compressibility here. Another pitfall here is you could get hung up on the biceps tendon behind the popliteal fossa, especially on patients who have quite muscular groups of muscles back here, well-developed calf muscles and hamstrings. You're gonna sometimes get hung up on the hammy or on the tendon back here. So just keep that in mind. If you get hung up on the tendon and you're not compressing it, you go, oh, there's a clot here, but really you're on that tendon. So fall off the tendon. You can feel in the back of on your leg right now. You can feel that tendon. There's a pair of them back there. You be careful compressing those. You want to get off those tendons so that you make sure there's no clot there. Another pitfall here is the wrong vein. This is a superficial vein here in the muscle, in the thigh. This is not a deep vein. Deep veins are paired. You'll see paired venous and arterial structures here. So if somebody's compressing this going, oh, there's no clot here. Well, that's fine. There's no clot in the muscle vein, but that's not a deep vein. You want to be in the common femoral vein, or the femoral vein, or the popliteal vein, and that's not that one right there. That's just a small little muscle vein. Okay, so what do you think about this one here? There's this large anechoic area here. We're in the popliteal fossa. What else could this be? It's not compressing. We're kind of going up and down the back of the popliteal fossa there. Is this a giant clot here in the popliteal vein, or is that a Baker's cyst? In this case, it's a Baker's cyst. That's a outpouching of the synovium of the joint. Can cause a lot of pain, and when they rupture, the fluid gets into the tissue and causes some edema there in the back of the leg. Patients complain of popliteal pain. It's definitely in the differential diagnosis with the DVT when somebody comes in with pain behind their knee. But if this is one area where color might be helpful. If this was a big vein back here, I would expect to see the paired arterial structure with it, and sometimes color can help me feather out what is a vascular structure from a non-vascular structure. So I wouldn't expect to see any color, of course, in a cyst. This patient is a larger patient. They've got a large BMI here, and we're using the curvilinear probe, the C60 in this case, and we can make out, using that lower frequency ability to penetrate better, I can make out this nice compressibility here. So artery, vein, the vein is actually compressible. I wasn't able to see that initially with the linear probe, so I had to switch it down to a lower frequency, and we got some nice visualization there. Same patient now. I'm in the popliteal fossa, larger BMI. I can see that vein compressing quite well. Notice that all the structures, the venous structures, all seem a little bit smaller. Again, that's because we're using that lower frequency probe. We have a big wide field of view here when you're using that curvilinear probe. But that's okay. We got the answer we needed. Another thing I see sometimes, in the differential diagnosis is somebody with a red swollen leg. I'm wondering, is this a DVT or is this cellulitis? You'd be surprised how this can really befuddle us as clinicians. And one of the things that helps me feather those two things out is the structure right here. So if they got a red swollen leg and they've got a good compressibility of the venous system, but I see what looks like, what is that up there? That is actually a lymph node. And so a lymph node, when I first saw them, I thought, oh man, I'm looking at a DVT here. This looks like a clot or something. It's not compressible. But that is consistent with somebody with cellulitis. You'll see enlarged lymph nodes there. And if I see a nice negative DVT study and a juicy looking lymph node, I confirm that this patient actually has an infectious process and not a concomitant clot as well. The two diagnoses together, DVT and cellulitis, quite rare. You sort of have to go with one or the other, and this helps me do that. Another example here of multiple inguinal lymph nodes here, sort of as we're fanning through. And if you put some power flow Doppler and lower the pulse repetition frequency, you'll see flow throughout these lymph nodes here, and the little tree-like vascular formation. They look like miniature little kidneys. Well, that's what lymph nodes look like. Here's another case. We're just compressing here. It looks pretty good. So where are we? The vein comes to the top in the pop. The artery is down here. The vein is up here. And this is just what a normal negative DVT ultrasound looks like in the popliteal fossa. And now we're looking at superficial thrombophlebitis. This is looks like a bone in the arm in the upper extremity. And we're just seeing what is not a DVT. This is superficial thrombophlebitis, and there's some disagreement about how to treat this, but generally speaking, we don't anticoagulate superficial thrombophlebitis. And so, but this is what it looks like. You'll see clot here in the superficial system. All right, and then finally we're down here in the lower leg, And we're looking at the compressibility here. Just wanted to point out what bilateral negative DVTs look like here. We can see the left leg, and we're looking here at the right leg. The arterial structures are here, the venous structure is medial to it. This arterial structure is an older patient, so you can see some calcifications there in the walls of that arterial structure. Here now we're in the left femoral region. Here we're easily compressing, but wait a minute, what's going on here? There's a non-compressible portion, and this is what a DVT looks like here. We can see this non-compressibility and consistent with an obvious DVT. There's more superficial structures that do compress. I don't know if you saw those up here, right up here, but the deeper structures do not compress because there's a DVT. Another example here of just a popliteal DVT. We can see the arteries down here. The vein stays open with compression. Very large DVT seen here. If you look how dilated this vein got here. That's usually from a more chronic picture. And this was in the popliteal fossa. There's the vein, the arteries down here. Very large chronic DVT seen down there in the popliteal fossa. So just for some conclusions here, I want to see you guys start at this inguinal ligament and go all the way down through the adductor canal into the popliteal vein, knowing full well this is a tricky area to insinate. But between the deep femoral vein and this portion of the, quote, superficial femoral vein, you could miss up to 6% of isolated DVTs, according to one retrospective study. Here we are in the popliteal fossa with the bifurcation and trifurcation. You want to get all the way down through this popliteal fossa here. And by the way, once you find a DVT, at that point, save the video clip, and you don't need to keep on compressing because you could actually dislodge the DVT and it could become a PE. Thank you very much.